progress.
Good afternoon, everyone, and welcome to day 2 of the 2021 Virtual National Hospital Alliance Conference. Those that were able to attend day 1, thank you again for joining us today. And we are going to go ahead and get started. I do want to bring up the agenda for today so that you can take a look at the various topics that we have. So we will be touching on key policy issues, go over sister match and virtual support opportunities that we have, the decline in women's heart disease awareness, patients accessing their health data, maternal health, clinical trials, managing heart disease in the virtual space, and also offering virtual support. And then we will close out today closer to 3:30. So first, I want to go ahead and introduce you to Amy Friedrich-Harnick. She is our VP of Advocacy and Communications, who will be kicking off the first session with updates on key policy issues facing women with heart disease.
Thank you, Morgan, and welcome everyone. Thank you for coming back for day 2. I hope you were here yesterday for the first day of our conference, but if not, it's all being recorded, as is today's conference, and so you will have access to all of the presentations and videos from yesterday and today available to you. So we'll be sending those out and posting those online. So thank you again. And I just wanted to spend a little bit of time here in the beginning talking about giving you all an update on what Women Heart has been up to as it relates to our policy work at the federal level and kind of where we're going from here. Because as you know, policy and advocacy has been a key component of Women Heart since we were founded to ensure that all women living with and at risk of heart disease have access to the good quality care and support that they need. So I'll start here with the first slide to just give you a quick overview. This is, we came out in early 2019 with a federal policy agenda that really went, the purpose was to help show and guide our policy work and make clear the issues we're going to work on. So over the last 2 years in the last Congress and the last half of the administration previous, these were kind of the areas that we focused on, making sure that there was access to coverage and care, continuing, a lot of the policy priorities that we've had for years, making sure women had full access to cardiac rehab, looking at participation in trials and research, full funding for research through NIH, as well as prevention programs at CDC. And I would say maybe the newest area of work that we've embarked on the last couple of years has been around heart disease and pregnancy and the interplay between those two, particularly in light of the fact that the maternal health crisis facing especially Black women in this country has come to a lot of prominence and a lot of urgency in the policy space. And so we wanted to make sure we were part of that solution. So these are the policy issues we've been working on. I suspect many of these will stay into the next couple of years. We are currently in the process of developing our next iteration of a policy agenda, and much of this will stay, but there will also be some tweaks, obviously, just to account for a new time and as well as a post-COVID era. So next slide, what we've done in order to inform the next iteration of our policy agenda is earlier this year, we sent out a survey, and we tried to get it as far and wide to women living with heart disease, just to start to understand what they care about and what their experiences are like. We obviously have tons of data and tons of work that we've done over the years to understand women's health stories, their heart stories, their experiences. And this was similar, but we really wanted to also capture what do they care about and think about in the broader space outside of their own experience. How does that experience that they had inform the issues they care about and things that they would like to see groups like Women Heart engage in? So we put the survey in the field. We had 155 women living with heart disease respond. And you can see, of course, take the results that I'm going to give you with, some context, because obviously there's a certain group of folks that we reached more than others, and we were less successful in some ways than I would have liked to see. I was very happy that at least a third of the respondents were not champions, because we know champions are amazing and they come with an especially high level of interest and awareness and passion for all of this, which is amazing. But I'm glad that we were also able to capture the thoughts and opinions of folks who aren't as deeply engaged in volunteer work around this space. As you can see, the vast majority of our respondents were over 50 years old. And unfortunately, the vast majority were white. So there's definitely lessons to be learned here for ourselves at Women Heart as we go in the future with further research, to work harder and use innovative tactics to make sure we're reaching a broader and more diverse group of folks. But this is what we got. And so the next slide, what you can see is we asked a series of questions about patients' experiences. This was kind of the first part of the survey. And we had a series of questions related to, have you ever experienced any problems either accessing or affording care itself, healthcare itself, and then separate questions related to medications and prescription medications and affordability and access in that space. And in general, if you looked at the responses and kind of put them all together, about a fourth of respondents did report having had some experience in the past with either accessing, affording care or medications. And so obviously that's a really important data point for us as we continue to do our advocacy work around access and affordability. 39% of the respondents agreed with the statement that at some point in their healthcare journey, they struggled to get an accurate or timely diagnosis. This was not a surprise, and something that we just wanted to kind of confirm, but we know that getting a timely and accurate diagnosis is a challenge for many women. So it's an issue that we'll continue to focus on. We wanted to capitalize on the recent conversations around telehealth and experiences. So we asked a question about whether respondents had ever had a telehealth visit. The vast majority did and said yes. And of that, the vast majority of those who had said yes, it was since COVID-19. So not a surprise, but we know that, COVID really changed the landscape when it comes to telehealth. And there's a lot of room and policy space to be had going forward to figure out what that's going to look like for the future. Of the respondents who had experienced a visit, our respondents, for the most part, said it was a positive experience. Many still said they would prefer in person, but there weren't a ton of people who said, no, they hated it and they would never want to do it again. So it is something from a policy perspective we'll continue to explore. And then we asked a question about, just to tap into women's experiences with care, and 3 in 5 respondents said that at some point in their healthcare journey, they didn't feel heard or understood by their healthcare provider. So again, pointing to a need for us to really continue that education for women and patients, and promote self-advocacy. So next slide. We also asked what they were interested in. And so we presented this list basically and a few other issues. And these were the ones that got at least 30% or more interest. And we allowed people obviously to check 2 or 3 options that they cared about. But perhaps not surprisingly, the most common areas that that the women in the survey were interested in from a policy perspective was work around prevention, work around missed or delayed diagnosis, access to cardiac rehab. So again, this is something that we will continue to work on, because a lot of the women that we talk to both loved their experience with cardiac rehab and found it to be very important. But also a lot of folks talked about barriers to that. Either they weren't referred, they didn't learn about it till later, or they know from women in their support groups that it was a challenge. So that will continue to be something that we work on. And then to a similar degree, there was interest in funding and research and participation in trials and disparities and coverage and cost. So that just gives you a snapshot of the folks that took our survey, what they were interested in. We're in the process of putting this kind of all together in a document so folks can dig into the data much more deeply. So that's a snapshot of that. Next slide. This survey was kind of part of our overall effort to launch Advocacy Core last year. And so briefly, this is just kind of another offering that we now have for our Women Heart Champions. And the idea is for those champions who are the most interested in policy engagement and advocacy, to give them the opportunity to go deeper into that space. So we launched Advocacy Core in early 2020. And what we do is we hold quarterly meetings and webinars with our Advocacy Core members. Right now, we have almost 50 Women Heart Champions who've signed up to be part of this. And we provide, opportunities for deeper engagement with their legislators, keep them really up to date on what's happening in the policy space, ways that they engage, do trainings about how to be effective patient advocates. And this fall, we'll be doing a virtual lobby day with lawmakers. Normally, we would bring everyone to DC to meet with their lawmakers. We're not quite there yet, so we'll be doing that virtually in the fall with our Advocacy Core members and having them call their members of Congress. So that's been really exciting. And here you can see some of the key legislation that we have been working on this year. There's obviously, big initiatives that are moving through Congress, and we do kind of track and engage those. But I think what's been really kind of fun and exciting this year, at least so far, is that there's some really concrete pieces of legislation that we've really been able to engage in that really, hit at different aspects of what's really important for the women that we serve. And so there's a blog that we posted just a couple of weeks ago that as soon as I'm done chatting, I'll put the link in the chat here. But that blog goes into much more detail, or a little bit more detail, and has links to each one of these bills, but I can talk briefly about a few of them. The Carroll Act was introduced earlier this year, and this is a really exciting bill. It focuses on heart valve disease, which is something that we've been working on quite a bit, and in the last couple of years, really in partnership with Dignity Health and with Dr. Rachel Bond, to do research around heart valve disease and look at the how women are underdiagnosed and undertreated. So this piece of legislation starts out with giving some funding to NIH and some guidance to NIH to really dig into some of the areas of research around heart valve disease where there's gaps in knowledge and information, particularly around sudden cardiac death. And so, but we made sure that bill was brought into to include funding for awareness and prevention, and some of the other things that we know are really important, just to make patients aware of their risk factors for heart valve disease, and to be able to recognize signs and symptoms in themselves that may be heart valve disease. So that is a bill that is on the House and Senate side and seems to be moving and may actually get some traction this year. Protecting seniors through immunization. This has to do with access to immunizations for those on Medicare Part D, and just right now getting certain vaccines for older adults. There's a cost sharing element if they're getting that vaccine through Part D. So this would eliminate that to make sure we increase access to all the immunizations that are recommended for older adults and for those with chronic conditions. The next one, as you can see, obviously right in the heart of what we care about, access to cardiac rehab. And so this would, this was actually passed in legislation a few years ago to authorize advanced practice providers to be able to order and supervise cardiac rehab in Medicare. So that policy passed in Congress, but it was the effective date, because there was a cost associated, was pushed off quite a few years. So this doesn't actually go into effect until another couple of years. So what we're trying to do with this bill is to make that go into effect now, so that we're not waiting a couple more years, before we can increase that access for Medicare recipients and make it easier for them to access cardiac rehab. The next is a bill, the Chronic Condition Copay Elimination Act, just recently introduced. And that would require kind of expand, if you think about it, we now have essential health benefits that need to be covered, certain types of preventive care. This in concept, not in actuality, but in concept kind of expands that to say, look, there's certain very common medications, devices, screenings, things that are used to treat people with chronic conditions that includes diabetes, heart disease, among others. And so this would require insurance to cover those very common treatments and without out-of-pocket for patients. And then finally, right in line with that pregnancy bullet that I talked about in health and heart disease, the Block Maternal Health Momnibus Act was reintroduced. It's a huge bill that addresses so many different components of Block maternal health, which we support. And one in particular is to make sure that we expand Medicaid coverage to 12 months postpartum, when we know that in particular, lots of heart health implications could arise. So that's just a snapshot of some of the bills that we're supporting and that we'll continue to track, of course, more as they come up. But look for us to put out some more on that survey and an updated federal policy agenda. She'll be coming later this year, informed by that survey and others. So that's kind of what we're up to. Sorry, that was super fast, but I can take questions now. I think Morgan or Calandra, if you're monitoring the chat, I'm happy to take any questions.
Okay, it does not appear that we have any questions.
Okay, great. Well, you can find, I think I saw that the blog got posted into the chat, so you can check that out and check out all of there's a couple other blogs in there. If you do go in, Dr. Bond authored a blog about that heart valve research that I talked about. So all of that is listed if you kind of search through and look at the list of blogs that we posted in the last several months, and other policy updates are in there as well.
Thanks so much, Amy.
Thanks, Morgan. And I'm handing it off to you now.
All righty. Alrighty, so I'm gonna just discuss with you briefly about our Sister Match app and other programs that we've offered in transition to the virtual space. So our Sister Match program, this program was designed to provide that peer-to-peer support to individual women who are living with heart disease. Some women, they may want to start off in a group setting, or they may just want to speak with another women heart disease survivor. So we were given the opportunity for earlier this year to convert our program into a mobile app to help expedite the matching process. With many of our programs transition to the virtual space, this app, it will provide that one-to-one support before and after discharge from the hospital, as well as a replacement for virtual bedside visits, and also for virtual support group meetings. We are also able to use it as a promotional tool for Women Heart, as well as for our NHA members. Since its launch earlier this year and over the course of the last several months, many of our champions and our users, they've been able to provide us with very beneficial feedback for the app. So we've been able to work with our developer to fix any glitches, to make it a little bit more user-friendly, and to continue to have the matching process expedited as one of our main goals. You can go to, and over the next few weeks, we'll go ahead and deploy all of those updates. Next slide, please. Okay, and then here I just took a few screenshots from the app. Users, they can also locate support networks within close proximity to access upcoming meeting information and to also connect with the support network coordinator of that group, as well as other group attendees. Champions and users, they can also stay up to date with Women Heart news and campaigns. Next slide, please. And so some of our programs that you already may be familiar with, we've been able to transition them to virtual. And as things are opening up, some of them are hybrid. If you just go back one. Thank you. So our support network coordinators, they host monthly peer-to-peer support meetings over Zoom or in person. A lot of them, since a lot of states are opening back up and they've been so eager to reconnect with one another, they've been having their support network meetings at local parks. And our support network coordinators, they tend to have about 10 meetings per year. And we also encourage them to recruit co-coordinators. So sometimes if there are women who are attendees of their support network, and if they see that they may be a good candidate to become a Women Heart Champion, they'll recruit them to help coordinate their monthly meetings. And in addition to our support network coordinators, our other Women Heart Champions who are community educators, they typically host health fairs, various speaking engagements, media opportunities, and advocacy initiatives, as Amy shared earlier. So what we've been doing over the last year, we've been working with our partners to be able to provide guest speakers for the support network meetings, or lots and lots of media events for our community educators to participate in. And then all of our champions, they have the opportunity to participate in our Sister Match program, as I just shared. The bedside visits and cardiac rehab. Usually our champions go directly to the hospital and they sit with patients and provide them with educational materials through our Red Bags of Courage. And if you're not familiar or just kind of want to see our updated materials, you can go onto our website and you can search for virtual Red Bag of Courage so that you can see that information. And then all champions, regardless if their primary role is a community educator or a support network coordinator, they all can participate in community education opportunities. So now that things are opening up, yes, we have transitioned those to virtual, but now our champions are able to go back in person. And what we're doing is basically our champions, they can go in person, but it's their discretion, whatever makes them feel the most comfortable. If they are hosting support network meetings or community events at their hospital, they are to follow the hospital guidelines. Next slide, and that pretty much wraps it up unless anyone has any questions for it. Okay. All righty. Well, what we can do is I will go ahead. Next slide, I'll go ahead and introduce our next speaker. Thank you so much. So our next speaker, Dr. Harmony Reynolds, she's an associate professor of medicine at NYU Grossman School of Medicine, where she directs the Sarah Ross Soter Center for Women's Cardiovascular Research and is associate director of the Cardiovascular Clinical Research Center. Welcome, Dr. Reynolds.
Thank you so much. I'm really excited to be part of this group of people who are just energizing the fight against heart disease and the fight to support women with heart disease and at risk for heart disease. I'm charged with talking about the declining awareness of heart disease among women over the period from 2009 to 2019. And there are going to be some sobering facts here, but the whole idea is to arm this group with the facts so we can change them in the future. Next slide, please. So here are the facts about cardiovascular mortality trends in the United States. As we all know, there was a rise over time in cardiovascular death rates until about 1970, and then things started to improve. There were some bumps in the road there. But at 2010, we hit a new low point of cardiovascular death rates, which was great news. And unfortunately, we have seen a concerning trend in a higher and higher number of cardiovascular deaths. On the next slide, we'll see what this looks like for men and for women. Again, this group is probably well familiar with the idea that between around 1985 and around 2015, there were more women dying of heart disease, cardiovascular disease, even than men. That gender gap seems to have narrowed. That's a small success, but we have to worry because the rates are going back up. So why do women need to know about heart disease and stroke? It's the leading killer. Next slide, please. Here are the leading causes of death for women as put out by the Centers for Disease Control. Heart disease claims the lives of 21.8% of women who are destined to die in a year. That's just a little bit ahead of all forms of cancer combined. And if we were to add stroke to heart disease to get cardiovascular disease, we see that this is the leading killer. Next, please. As far as the education effort, the Go Red for Women Triennial Women's Health Survey has been going on all the way back since 1997 with the idea of trying to assess what women know about their risk of heart disease and how to act on it. And subsequent surveys were conducted every 3 years, hence this triennial name, through 2012, and then there was a gap until 2019. And 2012 showed good news. The awareness of heart disease as a leading cause of death for women had jumped from 30% of women surveyed all the way back in 97 to 56% of women in 2012. And at that point, the greatest gains had been among younger women. Next slide, please. So how are we doing now? Well, before I show you the results, let me tell you a little more about the 2019 survey methods. The survey was conducted with Harris Poll Online, and this is a panel of online respondents that's maintained by Harris Interactive. It includes several million people recruited from a variety of different sources, but the survey was online this time. As in the 2009 survey, there was oversampling of racial and ethnic minorities to try and replicate census figures, so that there were quotas for basically non-Hispanic, Black, and Hispanic women to make sure there was the proper group composition. And race and ethnicity were by self-report. Next. Here's the survey population. I don't know if you guys can see my pointer, but if we look at overall in 2019 here, you can appreciate the average age of the surveyed women was about 51. But there's a very nice distribution of representation of women in the various age groups. There were women surveyed between 18 and 24, but they're a new group, and I'm showing you trends, so we're not going to go over their results. And the race ethnicity makeup you can see there. There's also a good distribution of educational attainment, not as many respondents who had less than a high school degree, but some, and some with a postgraduate degree. Next slide, please. Household income, we see that the efforts did result in a nice distribution, including people from lots of different income backgrounds. Most of the respondents were married or cohabitating, but there are some with different marital status, and few had history of heart attack or stroke or diabetes, but about a third had a history of hypertension. And that'll become important when we show the awareness of those women with hypertension in the subsequent slides. Next, please. The critical knowledge points assessed that I'd like to go over with you today are, what is the leading cause of death among women? What are the symptoms of heart attack? And what are the first actions to take in case heart attack symptoms occur? This is pretty basic cardiovascular knowledge, we would say. Okay. First, with what is the leading cause of death among women? Next slide. Here are the changes in responses over this 10-year period from 2009 to 2019, where people were asked without an aid, what is the leading cause of death for women? And you can see that in 2009, 65% of the women correctly identified heart disease or heart attack, really cardiovascular disease, as the leading cause. And that went all the way down to less than 44% in 2019. Where is that gap filled? It's with designation of cancer as the leading cause of death. Now, cancer is an important cause of death. Fortunately, the things that we do to prevent heart disease often prevent cancer as well. But the thinking has been that it's important to know what the leading killer is because people might be more likely to direct their attention to prevention if they know what the leading killer is, and women are getting that wrong. Next. Here are the characteristics associated with more knowledge among women. And I know this is a bit small, but please follow along with me. And let's look at this rightmost column of 2019. The way these are structured, the higher the number of the odds ratio, because this is adjusted for all the other characteristics, this is each thing on its own. I'll show you adjusted for everything next. So the higher the number of the odds ratio, the better the knowledge was. So this shows us that the odds ratio for a decade of age was 1.42. The older the women were, the more likely they were to know. Last time I told you in 2012, there were bigger gains among younger women. Now we're seeing that older women are more likely to hold this knowledge here. Looking at race ethnicity, non-Hispanic white women were selected as the reference group, and you can see that every other racial and ethnic group has poorer knowledge about the leading cause of death among women. And these are big differences, a 54% lower knowledge rate among non-Hispanic Black women, for example. If we look at educational attainment using less than high school as the reference, you can see that this is a very graded increase. The more education people had, the more likely they were to know that heart disease is the leading killer. For income, there was not a clear association. It didn't seem to matter really what the income was in terms of this knowledge. And for people who had history of heart attack, history of stroke, history of diabetes, knowledge was about the same as for everybody else. But interestingly, within the sample, a larger sample of those who had hypertension, have been diagnosed with hypertension, a risk factor, just click the mouse for me so you can see that I've popped up keep going, click, click, click. You'll see some text. These women are at higher risk and they have less knowledge. The women with hypertension, definitely an important focus. Women were 64% less likely overall, and that's over here under heart disease, heart attack, and overall, to identify heart disease as the leading killer in 2019 as they were in 2009. Remember, lower numbers here, the further we go from one, the worse the knowledge. And this is now with adjustment for everything else that we've seen. Maybe we can say the Black and Hispanic women that were selected for the sample, if they had a lower education rate, maybe that's explaining part of it. No, it isn't. With everything adjusted, we see that minority women were less likely to have knowledge about heart disease being the leading killer, and still less likely, a greater decline in those racial and ethnic minorities. Let's look at age. So this is the odds ratio comparing 2019 to 2009. We can see staggering drops. The absolute percentage of women aged 25 to 34 who could correctly identify cardiovascular disease as the leading killer dropped by 41 percentage points. We've really lost ground with these younger women in particular. For the women in the oldest age category, 65 or older, we actually saw a little bit of an increase in knowledge, though not statistically significant. So the fall off really seems to be among younger women. It's in all racial and ethnic categories, but particularly in racial and ethnic minorities. Next, please. Okay. Oh, this is a point that I reminded myself with the mouse click. I'd forgotten I'm not controlling the slides. That the women aged 65 and older, they've had the longest time to be exposed to public health messaging, because the public health messaging really started around 1997, and maybe that's part of what we're seeing there. Okay, next slide, please. Next question, based on what you know, what warning signs do you associate with having a heart attack? And on the next slide, we'll get to some of the facts. Chest pain is the #1 symptom of heart attack in women, but women experience a greater number of symptoms than men. This has been shown in several studies. This particular version is from Virgo, which is an analysis of young people who've had heart attack. And we can see that both in women and in men, the most common symptom of a heart attack is chest discomfort. It doesn't have to be painful, can be discomfort, might not be characterized as pain. People might think it's indigestion, but at least there is some symptom in the chest in the overwhelming majority of heart attacks here among young patients. Less with aging, but still the majority of patients with heart attack have chest pain. Women are more likely to report additional symptoms. And one wonders if this can be confusing to the providers taking care of them, but also I worry that we have, in our effort to make sure that all of our people in the public know that women don't have to have the classic symptoms for heart attack. They don't have to fall on the ground. They don't have to be clutching their chest. They might not have chest pain at all. I worry that we may have gotten a confusing message and people don't necessarily even recognize chest pain as the cardinal heart attack symptom. Go to the next slide, please. And this is another study from Virgo in which women who were ultimately diagnosed with heart attack were asked, when you first went for help, did your healthcare providers think you were having a problem with your heart? Women were more likely to answer no, even though they ultimately were going to have heart attack. About 25% of these young women, the provider did not think of this right away. Why is this important when thinking about women's awareness? Well, we know that women need to be their own advocates, and our women heart advocates are trying to empower them to do so. So you need to know that heart disease is potentially your problem and that chest pain can be a cause of heart attack if you're going to help convince your provider to take you seriously, especially for those young women who are not the classic demographic for heart attack, but in whom heart attack is on the rise. Next slide, please. In the American Heart Association Triennial Survey in 2019, only 52% of women could name chest pain as a symptom of heart attack. And it wasn't very different from 2009, but it still concerns me quite a lot that the knowledge base is so poor, right? This should be 100%. People were variously able to identify pain in the shoulders, neck, arms, shortness of breath, numbness. They were a little bit able to identify some of these other symptoms. It would be nice if we could get to 100%, but we've got to get to 100% for chest pain, and I think also for shortness of breath, since those are so common. Next, please. Here are the data for signs and symptoms by race, ethnicity. And I know that there's a lot of information here, so I've tried to make it so we can focus on the big picture. First of all, the scale here is 60%. As I've said, this should be 100%, so please recognize that no matter how far across these bars go, there's a big gap that we need to make up. The darker bars are 2019, the lighter bars are 2009. So we can see that we're not making a lot of progress. For most of these symptoms, we're seeing a shrinking back in knowledge of being able to identify heart attack symptoms. And we can see that knowledge
right into my life.
Hispanic women. Next slide, please. Here we're going to look at age groups, and it's in a similar format. We can see that in the 65 plus set, and even in 45 to 64, small incremental gains in recognition of chest pain, but really not a lot of progress and some backward movement in the younger age groups. Next slide, please. Now the question, what's the first action that should be taken if you're thought to experience signs and symptoms of a heart attack? And I'll direct your attention to the first line, which has the most favorable response, call 911. Only half of women would call 911, and we're not gaining ground here. It's pretty similar across racial and ethnic groups and age groups, but it's not enough. So this discussion is a call to action to do more. Next, please. So in summary, 10-year differences in women's awareness related to coronary heart disease are cause for concern. There are critical gaps among younger women and women of color, while awareness remains steady in older white women, yet still not great. Women's awareness that heart disease is their leading cause of death declined markedly in the last decade, from 65% in 2009 to 44% in 2019. The decline in awareness was observed among all racial and ethnic groups and all age groups except women 65 and older. Awareness of heart attack warning signs was worse overall in 2019 than 2009, but particularly in women of color and younger women. Next slide, please. So why is this happening and what can we do? Just to begin this discussion, there are possible contributing factors to the declines in awareness, and they may be lack of risk conversations in younger women, women who are less likely to be told by their physician that they're at risk of cardiovascular disease than men, and I think that's something that you heard from the Advocacy survey as well. Misperceptions by patients and physicians that younger women may not be at risk, and a lack of coordination across healthcare providers. It would be helpful, of course, if all the physicians seeing these patients are bringing up heart disease, cardiovascular disease risk factors even, to try and get at this problem. And we really need that. We need a coordinated effort. At least one tiny bright spot is that awareness among the original target audience for the Go Red for Women movement, the older women, demonstrated continued awareness. But we may need new methods for a new generation. AHA is definitely on social media, but the message is not getting across as well as we would like, and we have to be creative in improving this. There's an urgent need to reach younger and diverse audiences of women to raise awareness on heart health. And I emphasize here health versus disease because all along, the question has been, what's the leading killer of women? And the theory is that that will motivate people, but I wonder if that's not the best approach now, or maybe it shouldn't be the only approach. Maybe a focus should be something that's more optimistic, a focus on health, a focus on small incremental changes that can be made, with also the what if. You know, what if this is what happens to you? Yes, I need to know what this is and I need to know what to do, but I'm going to focus on avoiding it by promoting health behaviors. Thank you very much for your attention. I think my next slide will just be a thank you, and I appreciate the invitation.
Thank you, Dr. Reynolds. We actually have a few questions that came in.
Great.
The first are, what are recommended strategies for hospitals to improve awareness?
We certainly think that our providers, all different types of clinicians, are aware of these facts, but I know that the message is not uniform and it's not getting through. You know, I have a 52-year-old woman who just had a heart attack. She's got a history of heart disease, and the paramedics came and because she called with chest pain and told her she was having indigestion and maybe she shouldn't bother to coming to the hospital. Everybody hears these stories. So until we've gotten to every single person in the healthcare system, we won't have perfect success. So I think general strategies, these are education strategies. You know, make materials available to patients, make materials available to providers. There should always be continuing education. And we have to go over all the facts in an effort to keep awareness up.
Okay, thank you. We have another from Hilly Page. He says, thank you for your wonderful presentation, Dr. Reynolds. Depressing reduction in awareness of cardiovascular disease as the leading cause of death in women. Do you know if any groups are planning a new awareness campaign, such as AHH, CDC, and of course, Women Heart?
I know that several of the stakeholders, including some you mentioned and a few additional, did a roundtable discussion pretty recently at which I also presented to try and brainstorm about how we can keep the messaging, but change the methods or improve the methods to try and get the word out. And I don't know what form that will take, but I know that we're not the only ones who are trying to work on it.
Thank you. Thank you so much. And just one, let's see, I think we have another one. Let's see. Okay. Is there information in these surveys for trusted messengers related to heart disease in communities, particularly those of women of color? Those for women of color?
I'm not sure I completely understand the question. I think that someone is asking, does the survey get at who women are going to for information? Do you think that's what is meant?
Yes, so I think I misworded it. Is there information in these surveys from trusted messengers related to heart disease in communities?
I don't think so. You know, it's a random digit dial in an effort to get a representative American population. So I don't think that they've gone specifically to messengers, and I agree that needs to be done. We need to hear from people who are having success in their communities, raising awareness, you know, what works for your community. And we need a variety of approaches. We need rural and urban approaches. I mean, it's not all about age and race and ethnicity.
Well, thank you so much, Dr. Reynolds.